Today we're very fortunate to have Dr. Frank Marchlinski from UPenn visit us. His contributions are enormous, and in this era of academic productivity as an industry, he has managed to stay productive, but his contributions have always been relevant and true to physiology. So it's really an honor to have him. He is also a statesman in medicine and always a resource for the rest of us for advice. And he's going to talk to us about non-ischemic cardiomyopathy. Frank?
Thank you for the invitation and the opportunity to be here. This is a topic, as you'll see, has been near and dear to me for 30 plus years. So I'll talk to you a little bit about what we've learned. Let me turn on the mic. A little bit about what we learned. Of course, I always want to start out by talking to everybody that's been involved with this process, including I have an incredible group of colleagues and fellows and staff, and our patients always contribute to this kind of information in a major way. Here's a list of all relevant disclosures. No one has ever influenced the content of any of my talks. So this is just an overview of what I'm going to touch on, or try to touch on. I do want to talk a little bit about PVC-induced cardiomyopathy, talk about what we learned about the anatomic distribution of scar. You have a diffuse cardiomyopathic process, but where's the scar that serves as the substrate for VT? Talk a little bit about progression of cardiomyopathy and challenge some of the ways people think about the nature of the beast in terms of progression. Talk about the epicardial substrate, which is really important in non-ischemics, how the endo is compartmentalized from the epi, and you've got to get to the epi in some of these patients. The importance of mid-myocardial scar and the outcome with ablation, and then finally just talk about where we're headed with some additional work and try to get you to help me. So a lot of the talk will be based on obviously our own clinical experience and a lot of our publications. We'll try to cite some other work, but it's going to be based on a large volume of clinical experience that we've had over the years. And we're busy VT ablation center, and over the course of about 15 years, we had over 3,000 VT ablations, and about a third of them are going to be for coronary disease, and an increasing number are for non-ischemic cardiomyopathy. About a third overall, but about increasing percentage of the patients that come to us have a non-ischemic cardiomyopathy. They're more challenging cases, and we're seeing more of them. And then there's, of course, the patients who present with what are referred to as idiopathic VPDs or VTs, typically from the outflow tract area, and have an associated LV dysfunction with their frequent VPDs. And this is the group I actually want to start off talking about. So here's the clinical scenario. A 42-year-old woman, slight awareness of an irregularity of pulse, mainly at night when she goes to sleep. She's aware that her pulse is constantly irregular. And this is the 12 lead, has a left bundle, inferiorly directed axis, VPD, and a bigeminal pattern consistent with PVCs from the outflow tract. She's seen at one visit, has an EF of 45%, gets started on ACE inhibitors, beta blockers, has no real clinical effect from the beta blockers, except feels lousy. And her EF on repeat is 38%. Her MR shows no scar. So that's the clinical scenario. And the clinical in question is, are the VPDs causing the cardiomyopathy? And when we were faced with this question in the late 1990s, we began saying, well, there's one way for an electrophysiologist to handle this, and that's not to increase the ACE inhibitors, but rather just get rid of the PVCs. And that's what we started doing. So EF 35% by Gemini, get rid of the PVCs with ablation, and see if the EF improves. And in this patient, it went from 35% to all the way up to 60%. Took about a year to do so. And in our clinical experience, and this is a report by Stavros Mantanakis when he was with us, 69 patients, EF depressed, many of the people with a left ventricular outflow tract PVC, probably because of the referral nature of the population, depressed function can occur with RV or LV outflow tract PVCs. And with ablation, and most of them we were able to acutely get rid of, 91% of the patients. Some of them were too close to coronaries, or we called it intramural when we just failed. And couple of patients recurred, but in the patients without recurrence, we see an EF improvement of 14%. In the patients who either failed or had recurrence, their EF did not improve despite the optimum medical therapy. So fairly concrete evidence that when you take the arrhythmia away, the ejection fraction improves, convincing evidence for us that it's worthwhile doing. In this paper, we also addressed two other questions. First, the question of whether patients with prior structural heart disease who develop PVCs and seem to get a worsening of function, can you improve their function? And what's in people with multifocal PVCs, you need to make things perfect. You need to get rid of everything to see the function improve. And we had 20 patients that had started out with documented prior infarction or a documented scar-related non-ischemic cardiomyopathy, MR abnormalities, developed PVCs, had a worsening in their function. We got rid of the PVCs, and in this group, LV function improved from 28 to an average of 36%. Now, if you can get that with an ACE inhibitor or biventricular pacing, you're happy. And this is what can occur by just getting rid of PVCs when they develop in patients with structural heart disease. And I think it's important to note. We also know that from this data that we didn't have to be perfect. Although the goal is to get rid of every PVC, some patients, especially with structural disease, may have frequent multifocal PVCs. And what we try to do is target the most frequent with the goal of decreasing dramatically the burden. And if we can get the burden to less than 5,000, and we'll talk about some of this information in a little bit about the frequency of PVCs and its relationship to the development of myopathy. If we get the PVC burden down to less than 5,000 per day, the EF would tend to improve. So it didn't need to make it perfect, but needed to get it dramatically improved. Now, the real question for a lot of us is, well, if this works, that's great, because you can reverse the cardiomyopathy. But can you identify patients that are specifically at risk for developing the cardiomyopathy? So you can either monitor them a little bit more closely, so you don't wait until your EF drops to 25 or 30%, intervene sooner, because you can anticipate trouble, or perhaps do it in advance of the development of the disease. So here's one of the first attempts to look at clinical characteristics that may predict or are associated, not predict necessarily, but are associated with depressed function. And this is from the Michigan group, Frank Bogan and colleagues. And they looked at PVC frequency. And this is a scatter plot. So they took all their patients that were undergoing a PVC ablation, and they looked at the frequency or the PVC burden in terms of percent PVCs per day, and looked at the ejection fraction. And they had a number of patients who presented with normal function but had symptomatic PVCs, patients with depressed function. And what they nicely documented was that there seemed to be a relationship. Now, they suggested a 24% cutoff, but I think when you look at the scatter plot, what's clear is the following. If you have less than 10,000 PVCs per day, and assuming there's some stable pattern, you've repeated the Holter in the same low burden, you're not likely to develop decrease in function. Or at least in their experience, wasn't the patients that they did the PVC ablation on for that reason. Some of them had symptoms, but none with depressed function had a burden less than 10%. So there seems to be an absolute threshold where you begin to be concerned. Also, above 35%, you can anticipate that there's a higher risk. So you're in bigeminy or trigeminy, you may, over time, anticipate that you may run into trouble. Though I must admit, I have a few patients that have had more often bigeminy than not, and I've followed for over 30 years and have not developed a myopathy. So I don't think this is 100%. But the key here is, though, if you look at the middle, between a 10% burden and a 35% burden, it's a shotgun effect, right? You can't look at a number in here and identify patients who might be at higher risk. You worry, but you really can't, it's not a clear-cut association. Now, this was our attempt at a sort of similar effort, but we looked at PVC burden, and we actually couldn't find a relationship between PVC burden, excluded all the people with less than 10,000, because I think if you include them, you'll always see a relationship. But if you exclude the people with less than 10% burden, less than about 10,000 PVCs per day, and you look at the relationship, it's hard to define a clear-cut relationship with the absolute amount or the location. But what we did find is that patients who developed the cardiomyopathy had a wider QRS with their PVC for the same general anatomic location based on the ECG morphology of the QRS complex that was occurring with their PVC. So it appeared that PVC QRS duration might predict the development of a cardiomyopathy. And in fact, if you looked at the numbers in the PVC duration greater than 150 milliseconds, had a higher sensitivity and specificity for identifying the being associated. Again, this is a snapshot of people who are undergoing ablation, so this is an association, this is not prediction of the cardiomyopathy. And this just shows you an example of patients who had normal LV function, were undergoing PVC ablation for symptoms, not depressed function. This is what their PVCs look like, PVCs from the same area based on the morphology, and developed the cardiomyopathy. And you see these PVCs tend to be wider. And what we believe, and have also shown now subsequently in patients who develop pacemaker-induced cardiomyopathy, that perhaps the PVCs are unmasking, or the pacing is unmasking some underlying fiber disruption that's already present. And when you add the stress of RV pacing, or you add the stress of frequent PVCs, you develop a cardiomyopathy. Now, I said this is a snapshot, this is an association. So we went back to our database and tried to find a group of patients where we had prospective follow-up, where we didn't intervene, but we started with a snapshot of an image of their QRS complex when their LV function was normal, and they were followed for a period of an average about at least 6 months of follow-up, okay? So we looked at these patients, and we identified 45 patients who started out with normal LV function. We looked at their baseline PVC QRS duration and divided the patients into two groups based on their outcome during follow-up, those patients who stayed with normal function and those patients who developed a cardiomyopathy. And what we identified, true to what we demonstrated in the snapshot analysis, was that patients who start off with a wider QRS with their PVCs were more likely to develop, this is prospective data collection, develop the cardiomyopathy. So again, consistent with the possibility that some patients start out with minor degrees of fiber disruption, maybe from microfibrosis, viral syndrome, whatever it was, and then add to it a stress, whether it's AFib burden, whether it's frequent PVCs, whether it's pacing, and they'll demonstrate in response to that stress the development of the cardiomyopathy. So, Clea, what does this mean clinically? Well, it means that if you see somebody with PVCs and their QRS complex is wide, you worry more. Don't worry about everybody, but you worry less if the patients have a QRS that's under 150 milliseconds with their PVC. So here's just a clinical example, and you can see the LV getting bigger, dilating, decreasing in function over time. We were able to intervene in this patient and reverse the cardiomyopathy. But I think the idea of getting extreme cardiomyopathy and waiting till they get to 35% in terms of the EF before you intervene is probably not a good idea. And we want to intervene when we see patients, particularly those with a high PVC burden and those with a very wide QRS, probably intervene a little bit sooner, as soon as their EF seems to drop to high normal or low normal range, and their LV perhaps changes in terms of its anatomy, dilatation, etc. And I think it's probably pretty reasonable. Not to say we should ablate everybody with PVCs or Gemini, the asymptomatic patients, no. But worry a little bit more, follow a little bit more carefully, intervene a little bit sooner, especially if you have these clinical markers. All right. So let's talk about non-ischemic cardiomyopathy that develops not because of PVCs. We're not quite sure why it develops in a lot of patients, but let's talk about the patients with a fixed anatomic abnormality. So how do we index scar in these patients, right? If you're an echocardiographer, you'll do it with focal wall motion abnormalities. You'll talk about increase in echogenicity, regional thinning, a bunch of things that have been described. If you're a nuclear imager, you may say there's patchy abnormalities, some PET scan abnormalities if there's inflammation, gadolinium enhancement. Well, electrophysiologists look at one thing, and that's electrograms. And electrograms tell you a lot because if you look at the pattern of the electrogram in a healthy heart, when you have electrodes positioned over healthy muscle, recording activation, you see rapid activation as electrical activity travels from one healthy cell to the next, and it creates a large amplitude, relatively narrow deflection. In contrast, when you take a patient with scar, for whatever reason, and fiber disruption, you have discontinuous activation through the scar, sometimes actually jumping slowly from one muscle bundle that's viable to the next. And all of a sudden you change the characteristics of the electrogram so it has a decrease in amplitude and it has this multi-component characteristic that's typical of fiber disruption and scar, and quite characteristic. So we use electrograms to identify scar, and we've been doing it for a long time. We started out basically in the 1980s. This is my friend Dennis Cassidy. I was one of the dots here between Cassidy and Josephson. And we started out by saying, well, how do you characterize a normal electrogram? And what we did was, well, we can either get pathology, and that's difficult in a normal heart, and it's difficult in humans, even in the operating room at that time. And so we said, well, let's do it statistically. Let's define normal as being a statistical definition, as we'll get recordings in healthy hearts in 10 patients. And we would sample from 12 sites in the ventricle. And I think the most amazing thing about this is a non-steerable catheter. And we were guided by fluoroscopy alone, and we would very determinedly sample from 12 individual sites. And there's no online analysis. Dennis would stay until the middle of the night measuring the signal amplitude and duration. But what it did was allowed us to say, look, 95% of the signals have an amplitude with this typical electrode catheter, with a typical filtering system that we're using at that time, 30 to 500 hertz, had a signal characteristic where the amplitude was greater than 3 millivolts and a duration was less than 70 milliseconds, and we had an amplitude to duration ratio. And we defined normal, likelihood, statistical definition of what a normal electrical signal would be. And we said, let's look at, with these definitions, then, what abnormal hearts look like that can generate ventricular arrhythmias. And again, we did this. The most amazing thing is we did it in several hundred patients with a non-steerable catheter guided by fluoroscopy. But we sampled, and we determinedly get all these 12 sites. And what we demonstrated was that people with coronary disease and VT tended to have a lot of abnormal electrograms. So as I said, they have a lot of fiber disruption if they get VT. They have a lot of scar. And you can identify the scar with abnormal signals, fractionated signals, signals that were recorded beyond the end of the QRS complex late. And if you look at non-ischemic cardiomyopathies, our sampling was smaller, but we can see even then there was a difference in people who presented with non-sustained VT, cardiac arrest, and sustained VT. People with sustained VT would tend to have more electrogram abnormalities, fewer than people with coronary disease, because now we know some of it's epi, not all endo. But you can use electrograms to tell you a lot about the disease substrate. Fast forward at the middle of the 90s, this technology became available. And that is electroanatomic mapping system magnetic electroanatomic mapping system, where you could couple electrical information that you could acquire from the tip of the catheter. So this amplitude, duration, you can look at activation, and couple it with the anatomic location in 3 dimensions. So you can move the catheter inside the ventricle and create a map of that ventricle that images the anatomy of the endocardium, and then you can display signal characteristics, either activation or amplitude, and create an image of the endocardial surface that mimic the surgeon's view of the endocardium, if you make the assumption the electrograms were telling you a lot of the anatomy. And when we did this with this new system, we said, well, we better revisit this, what's normal. And so we went to patients without structural heart disease, and dizziness or syncope undergoing EP studies, and they had their ventricles mapped. And we mapped the right and left ventricle and demonstrated that in this system, with a different catheter design, electrode tip size, filtering, had slightly different cutoffs. And normal in the left ventricle, 95% of the signals were greater than 1.62 and 1.47 in the right ventricle. We said 1.5, 1.7 might be a good cutoff to use to identify healthy hearts, what's normal voltage versus abnormal voltage with this system. And so if we map the endocardium of the right ventricle and left ventricle in healthy hearts using this color display, where anything greater than 1.5 millivolts represents a healthy signal, most of it will be represented, the heart's endocardial surface will be represented by the color purple. So 95% of the signals are over that cutoff, and you'll have isolated, non-contiguous signals that have a lower amplitude. That's a healthy heart. If you take patients with coronary disease, big anterior infarction, this is what you see. So this is a shallow RAO, LAO view, and this is dense scar at the apex consistent with a densely infarcted aneurysmal area, a transition zone back to healthy muscle towards the base. And we were happy as we began to use this system that this was mimicking what a surgeon's view was of the myocardium, looking at the densely infarcted aneurysm, removing the aneurysm, he'd identify an extensive area of border zone. When we were using surgical ablation, we would be removing this border zone. So everything was being consistent, that the electrical information from the voltage mapping was mimicking the anatomy and the surgical view in the operating room. What was interesting to us was the distribution of scar in non-ischemic cardiomyopathies, because this came as a surprise. You would think that with a diffuse disease process, and most people thought this, by the way, a diffuse disease process with non-ischemic cardiomyopathy, you'll have diffuse scar. It'll vary from one patient to the next. One will be apical, another will be basal, septal, lateral wall. It'll vary. But it wouldn't have a specific anatomic distribution in patients with ventricular tachycardia. As it turns out, that wasn't true. It does have a specific anatomic distribution. In well over 90% of patients, that distribution tends to be with the scar greatest surrounding the valve structures. And it doesn't matter the non-ischemic disease process. Okay. Left ventricle, right ventricle, perivalvular scar was identified. And this is the example of a transplanted heart, the pathology that was recorded associated with this endocardial recording in the left ventricle. And this is the tricuspid valve. Low voltage is, again, this dark red color whenever I show these displays surrounding the tricuspid valve and associated with this pathology. So it's interesting. You have a diffuse weakening or decrease in function, but scar that serves as the substrate for unclear, that's denser around the perivalvular region. And that is important for us because suddenly we said, well, this is where we have to look. And technically, it was pretty challenging to get to these areas, so it was very important to realize that the scar was distributed in these areas, so you make purposeful catheter manipulation to get to these areas and sample correctly. And you know, it's interesting, as I said, it didn't matter what the disease state. So this is data from Chagas disease. Sorry about that. This is data from Chagas disease. from the group from Brazil, South America. And what they identified in their patients was, again, perivalvular origin of ventricular tachycardias, surrounding, not uncommonly, the mitral valve, right in front of the aortic valve, as the common substrate. Rare, even if they had apical aneurysms, because Chagas disease sometimes had an apical aneurysm, rarely would you actually get an apical VT. Common perivalvular scar. So there's this common pathogenesis for all these disease processes. We don't quite understand why the dense scar in these areas, despite the diffuse disease process. More to come on that. Progression of the scar. Now, most of us think as for non-ischemic cardiomyopathies, we don't understand the triggering events, we don't understand progression. In ARVC, it was assumed to be a dysplastic degenerative process. You'd start off one day like this, and over your lifetime, you gradually, but ever relentlessly, progress in terms of your scar formation and develop this type of right ventricle, where red again indicates dense scar, purple, viable myocardium. That's what was thought. When we started looking at this in our patients, we got surprised again, because we expected we'd bring patients back years later and remap the endocardium. We did this, and much to our surprise in the patients where we brought them back, the scar wasn't progressing. Whatever was there initially was there on repeat. 92 months later, 4 years later, 6 years later, no progression. In fact, in this initial publication, it was 9 out of 11 didn't progress. Now we have 16 out of 20. So a couple do progress. We'll talk about why that happens. But the scar does not progress. Now, all of them tend to dilate over time. So the dilatation and remodeling that occurs can be adverse, but the scar progression is not guaranteed. Now, why is this important? Well, as soon as we saw this, we said, listen, if this scar doesn't progress, then the reason for having a bad outcome with ablation may not be because of scar progression. It may be just because we don't know how to do it right yet. And that's, we hope to try to prove, and that this is the original data from the Hopkins group, where they just collected data in the registry of people that underwent ablation. This is one of their own clinical experience, but it had a registry, and they said outcome was terrible. But they did suggest in this publication in 2007 that this was probably because of progression. And so we were thrilled when we didn't see progression, that maybe if we figure out how to do this in terms of the ablation, maybe we can make it not progress. So let's talk about where the scar is and some of the challenges. So first about epicardial substrate. Now, pathologists, certainly in ARVC, and a lot of non-ischemics have been telling us for a while that disease can be epicardial. Endocardium can look normal, abnormality in the epicardial. In ARVC, there tends to be typically much greater epicardial than endocardial abnormality. And just before the turn of the millennium, the group from Brazil, they had to deal with Chagas disease. I want to say this is an interesting story, the Chagas disease story, because they were so frustrated with endocardial ablation. They're struggling one day in the lab, and they said, I think this is outside the heart. And the anesthesiologist, so some of them are really good guys, but they said to him, why don't you go to the outside? I said, well, how are we going to get there? He said, well, why don't you use a TUI needle, like we do with an epidural? He said, yeah, but the heart's beating. How are we going to do this? So you probably could do it. And that's exactly what they started. So gaining access to the virtual space epicardium with a TUI needle, and then advancing a guide wire, and then once that happens, you can pretty much do anything you want there, as long as there's not adhesions. And that was the technique that was developed and pioneered that allowed us then to move forward with gaining access to the epicardium when we struggled with endocardial ablation in these patients. Importantly, when we started doing this and you got to the epicardium, you realized, well, it's not quite the same as the endocardium. The endocardium's got only endocardial myocardium. So you can use voltage characteristics to reflect disease very reliably. On the epicardium, now you have additional structures that play a role in creating an amplitude assessment of the voltage. Specifically, if you take the heart and then put in an insulator like fat, or put coronary vessels and then record over those structures, you'll have a different amplitude than if you're recording directly over the myocardium. So you have to account for that. And indeed, some of our initial efforts when we went into the epicardium, we said, we have to look at the effect of fat in coronaries, and low voltage when you're recording from these areas are not uncommon. And if you ablated everywhere where there's a coronary, you'd be in trouble, obviously. So you need to determine that the signal characteristics, not only the amplitude can get blunted, so you can't use now the color red any longer, but you have to look at the signal characteristics. Because although the signal amplitude gets blunted, when you record over these structures, the signal characteristics don't become abnormal. They're not wide, they're not split, they don't show these late activation. They're just blunted because you're recording through an insulator. So we learned also that you have to spend a lot of time looking at signal characteristics and then tagging them and labeling them. So it gets a little bit more challenging. But now we know, and we learned to do this and learn from this experience that it's probably even valuable in the endocardium in selected patients, that you'll spend time looking at the signal characteristics, and signals that have to be, in order to serve as a substrate for VT, have not only to have a low amplitude, but should have these signal characteristics consistent with disrupted conduction, which include these wide split and multi-component electrograms. We had some other challenges on the epicardium. The phrenic nerve. The scar, remember, is perivalvular, basal and lateral, frequently in non-ischemic cardiomyopathies. So this is a lateral view of the left ventricle. And the structure that runs in the pericardium, just over the epicardium, is the phrenic nerve, left phrenic nerve. And one can create phrenic nerve injury if one doesn't identify, and in selected patients is actually using a big vascular balloon, push the phrenic nerve away from the epicardial surface to be able to ablate the epicardium. We also learned that you can monitor the effect on the phrenic by pacing. And where we gained access to the phrenic without doing a separate transeptal puncture and left atrial appendage, because that's another option, because it's running over, you see the left atrial appendage area. So if you put a catheter up there, you could probably pace. Well, he said it also runs all the way up here in the next to the left subclavian. So we routinely will stick an extra catheter up in the left subclavian and pace with high output and capture the left phrenic when we're ablating in this region to make sure we don't injure the phrenic nerve. So there are coronary challenges, you've got to define the anatomy, the phrenic nerve challenges. But the epicardium, we recognize what the pathologists were telling us for years, that the abnormalities there, and that's how you have to go to ablate a lot of these arrhythmias. In our clinical experience with epicardial ablation, put this together a couple of years ago already, so a little bit old, but see most of the patients that we have to go to the epicardium have either non-ischemic LV or RV cardiomyopathy. So that's the main reason we have to go there. Now, the real issue is there's still some risk involved with sticking the epicardium and getting access to this virtual space. We tend not to want to do it unless we have some conviction that it's going to be worthwhile. So we've worked very hard to try to create criteria that allow us to identify an epicardial scar and VT before we attempt access. So what are those criteria? First of all, we now, on a routine basis, always use imaging. So no one gets to our laboratory, well, most people don't get to our laboratory without some degree of imaging, usually with an MR. And we've learned that you can image people with devices. We've not had any consequences. We have a protocol for doing everybody. We use some processing techniques that we collaborated on with a group from UCLA to cancellation sort of processing, so you can get rid of some of the artifact of the devices, and we routinely image everybody. And you can identify in some of the people gadolinium enhancement that suggests the presence of an intramural and/or epicardial scar. This is one such example. We also rely on intracardiac echo in the EP laboratory, and in some of the patients where we identify a healthy endocardium and we see this echogenicity, an intracardiac echo, we know this is a marker for the high likelihood that we'll see evidence of areas of low voltage and abnormal electrograms towards the epicardial surface. We also realized that the 12-lead ECG during the ventricular tachycardia can tell us some clues that it's something maybe epicardial. And this is from the work from the Barcelona group, where they just looked at interval criteria. That is, if you have slurring of the QRS complex, and they developed a number of intervals that sort of identify this kind of slurring, sort of like WPW. Slurring of the initial portion of the QRS complex, more likely to be either very diseased myocardium where the VT is coming from, or epicardial. So if you see it, it suggests an epicardial origin. And there's this maximum deflection index. I'm not going to get into it. The bottom line is these interval criteria tell you that there's slurring in the beginning of the QRS complex. When you see it, it suggests it's an epicardial origin for the ventricular tachycardia. We also looked at morphologic criteria. If you think about it, something from the outside of the heart will be moving away from a specific lead that's recording right over the area where the VT is coming from. So if you have a VT coming from the basolateral left ventricle, and you record from lead 1, from the endocardium, okay, you'll have an R wave in lead 1. From the epicardium, you'll see a QS complex. Here's examples in lead 1 from the epicardium of this QS complex, and from the endo, you'll tend to see the R wave. So Q waves where they don't belong, not with coronary disease, because coronary disease patients have Q waves everywhere, but in a non-ischemic cardiomyopathy or idiopathic VTs, it suggests that it's epicardial. And again, an algorithm that we developed that had a high degree of sensitivity and specificity, where we incorporated some modified interval criteria with this presence of the Q wave to identify a probable epicardial origin for ventricular tachycardia. And we also started thinking about electrograms. So, the bipolar electrogram, where we typically record activation between two poles. And that has a relatively speaking narrow field of view, and it depends how wide the inter-electrode distance is and the size of the electrode, so there's a lot of variables, but still the field of view is narrow. When we were starting to look and say, can we identify something that's a little bit further away, we said, well, can we look at unipolar signals? Well, unipolar signals, which attempt to record from the tip of a catheter to a reference that's at a far distance, or in this case, Wilson Central Terminal is the reference, like the surface ECGs. Can you pick up signals that are abnormal at a distance and identify intramural or epicardial scarring? So we started to look at unipolar electrograms, and just like we did with bipolar signals, we said we have to determine first what's normal. What's a normal unipolar signal in the right ventricle and the left ventricle recorded from the endocardium? So we had the opportunity in patients, someone with idiopathic VTs, where we went to the endo and went to the epi with no structural heart disease. We said these are our definition of a normal group of patients, and looked at signal characteristics. And in the right ventricle, after sampling 1,000 plus electrograms, demonstrated that 95% of the signals in the endocardial on the unipolar signal were greater than 5.5 millivolts. So we said if we use that cutoff in people with normal hearts, everything should be purple, and it is. But how about patients with ARVC who frequently only have an epicardial scar? So endocardium normal or near normal, unipolar signals, extensive area of abnormality, predicting the presence of extensive area of low voltage, and each one of the black dots are multi-component fractionated electrograms. So the unipolar signals pick up this far-field anatomic abnormality. And the cutoff we use is 5.5 millivolts. It was defined in healthy hearts, and it's a valuable cutoff for defining in patients with normal endocardial voltage the presence of probable epicardial substrate. We did the same thing in the left ventricle. So left ventricle, 6 patients, healthy hearts, everything's purple. 95% of the signals are greater than 8.3 millivolts. That's the cutoff that was determined. You apply it in patients with non-ischemic cardiomyopathy and VT, normal bipolar voltage, their endocardial unipolar voltage is abnormal, predicting the presence of an abnormal epicardial abnormality. Now, one more concept of compartmentalization of the endo and epi. When we start ablating in the patients with ARVC, we said, well, they have a thin-walled right ventricle. Why can't we penetrate from the endo to the epi with our RF energy in a thin-walled structure? And here's one clinical example where we had a patient. This is endocardial voltage map, epicardial voltage map. And this was an ablation was performed on the endocardium at a site that looked a little bit early. It was appropriate for ablating. We would terminate the VT 30 seconds after applying the RF, as high as we could, energy value. And the VT would terminate, and 30 seconds later, we would restart it. So we went to the epicardium. On the epicardium, we found this site that was directly opposite, and I left the endocardial catheter in place to show the proximity of the endocardial catheter and the epicardial catheter. This is just a catheter tip away, so about 4 millimeters away. And yet, on the endocardium, we could apply the energy, deliver it for a couple of minutes, terminate the arrhythmia, but the arrhythmia would recur. So we weren't effectively damaging the epicardium, despite the fact it was only 4 millimeters away. And we said, geez, this scar that's there must be serving as an effective anatomic barrier to our RF energy. We refer to it as, well, it seems to be compartmentalizing the endo from the epicardium. And when we began to look at other phenomena related to this same issue, we said, well, you know, this is pretty interesting that the endo seems to be completely compartmentalized from the epi related to activation. So if you look at a normal heart, this is a voltage map from a patient with a healthy heart, endo and epi. This is an activation map rather than a voltage map. So it looks at the timing of activation. This red is the earliest activation. So earliest activation on the endocardium occurs, goes in 5 milliseconds right to the epicardium. So there's no delay. Endo to epi in the right ventricle, 5 milliseconds later, directly opposite. That's what happens in the healthy heart. You take the patients with ARVC, they can have a totally normal endocardium. And the epicardium is not getting activated by this direct activation from endo to epi. The activation has to find the edges of the scar and then proceed in a layered fashion to activate the endocardium in a very delayed and an abnormal, epicardium in a very delayed and abnormal way. So it goes from endo, hits the barrier, has to go to the edge of the scar, and then travels through disrupted myocardium in a layered fashion. This concept of layered scar is really important because frequently layered scar can't be picked up by MR. So you can fab layered abnormalities on the epicardium that may be responsible for a lot of diseases, like Brugada syndrome, maybe early repolarization. Other phenomena, certainly in this state where we can't see an MR abnormality, and yet there's a layered scar that can exist. A few comments just about the septum. Septum is, back end of the septum is adjacent to the aortic valve area. And so clearly you would anticipate, as in this patient with giant cell myocarditis, so another disease process. but the same anatomic distribution of the substrate, back the densest scar towards the base, involving the endocardium. You see a wall motion abnormality on echo, you see the gadolinium enhancement. Okay, everything consistent with the abnormality that's there. Here, the abnormality was clearly visible on the endocardium, and it was visible, this was a transplanted heart, ultimately, so you got to see the pathology. It was pretty dramatic. What we realized as we began to do this, of course, is that there's endo, there's epi, and then there's mid-myocardial. And the pathologists have been telling us that. And mid-myocardial scar frequently can serve as the substrate for VT. It became very important, especially in the septum, to be able to identify this mid-myocardial scar, because this is an example of a patient who has normal endocardial voltage map. He has these two VTs that look like they're exiting right off the top of the septum. We go to the epicardial, gain access, take this risk, do this voltage map, everything. This is a normal voltage map. The low voltage is just in the area where there's dense fat or coronaries. In this patient, when we image with MR, we see this mid-myocardial scar. Importantly, we now recognize that the unipolar signals tell us that there's scar at a distance. It doesn't tell us it's necessarily epi or on the other side of the septum. So we can use unipolar signals also to look at mid-myocardial scar and use it routinely to identify and to corroborate information that's shown on imaging. And for the electrophysiologist, the audience, if you're not a believer in unipolars, there's another trick you can use. You can also just pace the right side of the septum and see how long it takes to get to the left side of the septum. Normally it takes 28 milliseconds. Okay, never more than 40. Healthy heart, from right septum to left. But if you take a patient with unipolar abnormality, even if you've not gotten an image beforehand, and say, I want to corroborate that this is real, and if you pace the endocardium on the right ventricle and record from the left ventricle, it'll take a lot longer. It frequently would be so disrupted that the activation has to go all the way to the apex, go around the scar, and then go up the left side of the septum. So the left side of the septum will get activated sometimes 100 plus milliseconds after the right side of the septum. And you can use it to corroborate that there is a mid-myocardial substrate and gather the wherewithal to then do the ablation to target that mid-myocardial substrate despite a normal endocardial bipolar voltage map. Finally, outcome with ablation. So 2007, this was a publication that said progression of the disease, poor outcome. Outcome that was bad by 1 year. This is now one of our recent reports in ARVC patients where we've had outcome that extends out to nearly 5 years in these patients. So not just short-term follow-up, where with endocardial and epicardial ablation, the outcome has been changed dramatically. No recurrences, and more importantly, no VT storm and no amiodarone in this young patient population. So it has been a game changer, especially in the ARVC patients. In the left ventricle, it's been more challenging. We've learned that it's more procedures, more of them, 22% of them left on amiodarone to control their arrhythmias. It's been more of a challenge. We know that if you have a lot of structural abnormality and a very depressed LV function, VTs from the LV apex, your outcome's not going to be as good. The more extensive the substrate, the more complex it gets. But there is a difference. The outcome still is good, and importantly, especially good in terms of you look at elimination of VT storm and a decrease in the amount of medication that's used to achieve a reasonable degree of success. Finally, the future. Where are we going with this? Well, I hope somebody in this audience, because there are a lot of smart people, right? Yeah. But somebody tells me, why if you have a diffuse disease process, you have the concentration of the substrate that serves for ventricular tachycardia around the perivalvular area, the dense scarring around the perivalvular area. What's the mechanism for that? I think that, and why is it the same regardless of the disease process? I showed you giant cell arteritis, Chagas disease, the idiopathic, non-ischemic, the ARVC patients. You got the same concentration of the substrate. What causes the progression? As I showed you, people don't progress typically, but some do. Small percentage of our ARVC patients, half of our LV cardiomyopathy patients, you bring them back, and they've got disease progression. So what's the triggering mechanism? Can we prevent it? Finally, this is something I'm really excited about. You know, when you look at imaging in the non-ischemics, and you take every 100 patients, say, with irreversible LV cardiomyopathy, 28% will have patchy mid-myocardial abnormalities, 13% endocardial or abnormality, but most will have no gadolinium enhancement, despite the fact you have a diffuse decrease in function. And people assume we've got some microfibrosis and we need to do some more advance the technology before we get to image this microfibrosis. Well, what about electrograms? Can we get a handle on the reversibility of a disease process and the extent of the disease process better with electrograms than what we have with MR, at least right now? And again, this concept of looking at unipolar signals for identifying the presence of perhaps a irreversible microfibrosis. So here's our clinical experience. So we took patients with normal hearts, and this is a unipolar electrogram distribution. So as to be anticipated, because we got our data from another group of normals, they should have average signals that were about 16 millivolts, and only, in this case, 1.2% had less than 8.3 millivolt signals. So that's consistent with our data that we developed. Interestingly, when you look at the people with the reversible cardiomyopathy, remember I said that they may have some substrate abnormality, and that when they get their PVCs, then they're more predisposed. Well, their unipolar signals are shifted a little bit, 13 millivolts on average. 10% of their signals are less than 8.3 millivolts. And then if you look at the patients with the diffuse decrease in function without gadolinium enhancement, bundle branch reentrant patients, or just sample from the areas without gadolinium enhancement, without bipolar abnormality, and you look at their unipolar signals, much more abnormal in patients who have irreversible cardiomyopathy without having any image abnormality. In this patient, 58% had signal abnormalities, and the average signal was down to 7.6 millivolts. So again, this is the signal distribution in somebody with a reversible cardiomyopathy, sort of minimal unipolar abnormality. Patients with irreversible cardiomyopathy, normal bipolar signals, but unipolars are dramatically abnormal. And everybody uses this already. You look at an ECG, a 12 lead, and say, no voltage, they're in trouble. That's a big unipolar. It's a 12 lead. Okay? So you already do it. But this is sampling with over and over again from all areas of the ventricle to really get a detailed characterization of the signal amplitude. And this is just a graphic display of normals, reversible cardiomyopathy, irreversible cardiomyopathy. I'm hoping, we have protocol now, we've got our heart failure people convinced they're buying into it to help guide biopsies. And I think you can use the voltage characteristics to help guide biopsies. But we're also getting patients early in their clinical course with a presentation of a cardiomyopathy and doing voltage mapping to determine whether the voltage map is going to tell us, provide risk assessment, predict which patients will need an early ICD rather than that, the window that we're required to wait now because and try a bunch of different drugs before we put the ICD in. Will give us some idea whether patients are going to respond to heart failure drugs or biventricular pacing, which patients need early transplant counseling. So we'll see. I'm optimistic. Finally, again, this layered scar. MR may not show an abnormality. I think epicardial layered scarring, Brugada syndrome, early repolarization, and some of this sudden death in healthy hearts that we've not been able to describe, and pathologists miss because they don't even pay attention to the layered epicardium. They're looking at the myocardial muscle. So more to come in this important area. So covered a lot. Thank you for your attention, and obviously there's still more to come in this area. Thank you.
So Frank, I'll start with the first question. That was an excellent overview. Speaking of sudden death and ICD implants in the non-ischemic population, we know that the evidence is less robust in terms of survival benefit in non-ischemics compared to ischemics. Do you ever foresee a role of ablation as a tool solid enough to alter the natural history of non-ischemic cardiomyopathy so it could replace ICDs?
Yeah, I think, and unfortunately, the disease and the arrhythmia presentation with non-ischemic is frequently the minorities with uniform ventricular tachycardia. So that until we get an understanding sufficient of the substrate for VF and the triggers for VF, until that happens, we won't be using ablation as the primary role. And I still think that the ICD is not perfect, but still the mainstay of treatment.
Great talk. Quick question about the role of voltage map for diagnosis. I'm one of the heart failure specialists here, and we use MRI to help guide us in terms of the differential for non-ischemic, and we do a fair amount of biopsies. But often the biopsy is non-diagnostic. MRI is compromised in terms of artifact with devices in place. So can one use voltage mapping characteristics to distinguish the differential, sarcoid, amyloid, ARVs, to name a few?
It's clear the two things. One, you can use, there's voltage mapping signatures for a bunch of different disease states, sarcoidosis, et cetera, and especially when you combine unipolar and bipolar. There's now several publications came out of one of the guys that worked with us and then went up to the Mayo and has actually took the ball and ran with it and has been doing voltage-guided biopsies using unipolar signals assessment to help guide areas where you should biopsy on the septum. We're using it now to guide biopsies left and right ventricle with some promise. Obviously, you're still only getting a small bite, so it's always limited by that. And the unipolar signal's telling you there's disease, but it may be a few millimeters deeper to where you're actually going to pull off the myocardium anyway. So there are going to be some limitations, but it gives you an area where to concentrate your biopsy, where there's more likely to be an anatomic abnormality. And I think that's helpful.
We've been using some of that with Miguel's guidance. I guess what I'm trying to understand is if I still don't understand etiology, and I've already pursued biopsy, perhaps robotic guided biopsy based on voltage map, but does the voltage map characteristic guide me in, okay, the likelihood that this is, mid-myocardial, maybe a unique diagnosis compared to, let's say, amyloid. And I know there's overlap in terms of even gadolinium enhancement pattern.
I think the answer is there are some signature distribution patterns that suggest, an area that's more septal is going to be more likely to be sarcoid, et cetera. But I think the key is going to be, I think, if you look at the signal characteristics and you have dramatic unipolar abnormalities, you're probably going to have a irreversible process. And I think that much you can tell rather than the specific disease process. That's actually a pretty good idea. Say, can we go back and look at all our data and say, do we have enough of a signature? Because in my head I'm thinking we probably do, but I don't want to say that unless we review. But it's actually a good idea. I'll give you credit.
Yeah. Thank you very much for your intriguing presentation. My question relates to the impression that one gets from your presentation is whether macro or micro scar is essential and prerequisite for ventricular arrhythmias in primary cardiomyopathies.
Yeah. So
The challenge against that would be the case of arrhythmogenic versus dilated cardiomyopathy. In arrhythmogenic dilated cardiomyopathy, the primary and cardinal and the first manifestation is VT. Of course, in the absence of discernible scar, you may argue you may not detect it. But the same principle applies to dilated cardiomyopathy, in which VT is a late phenotype, not an early phenotype. How do you resolve that?
Well, a couple of things. One is that that we see the tip of the iceberg, right? You see ventricular arrhythmias that in ARVC, one can argue that are less likely to present, the people that die early with a sudden cardiac death, is not uncommon as the early presentation of a young person with ARVC, but they develop cardiac arrest. So they really have a VF arrest because their substrate may be, relatively speaking, small and perivalvular and therefore harder to identify, but I don't think they're electrically or separated much from the anatomy. I think the anatomy is just difficult to identify when it's small and around the perivalvular area. I think you're absolutely right. The more scar you get, the more likely you're going to have ventricular arrhythmias. And you're more likely to see extensive scar that's frequently layered in ARVC. And whether that is, my sense is you have a genetic predisposition, desmosomal plakophilin abnormalities, and then you get an inflammatory process of some sort, and you get the opportunity, because of the genetic background, to have a lot more dense scar, whereas the other disease processes end up being more microfibrosis. And still, as I said, the pathogenesis, still poorly understood. I'm fascinated by the whole thing. What you're saying is absolutely true. I now have moved to everything they're saying about an electrical stage and a non-electrical stage. I think it's just a matter of getting the right tools to image. They should coincide, and they tend to. You do tend to see VF arrest and VPDs more often early on, and then you get people with a big substrate. And whether that's progression or it just happens to be the people who've got a big insult end up with more ventricular arrhythmias, I'm still not sure. And again, that's the fascinating thing. I'm fascinated by the fact that we didn't see this progression that we'd anticipate.